So if you get a headache, right, you just swallow a pill and I don't know, an hour later the pain is totally gone.
Right, yeah, because the problem is isolated.
Exactly. The solution is targeted. But how exactly do you formulate a pill to, save a human memory?
Yeah, that is a completely different ballgame.
Because you're no longer just trying to quiet a throbbing nerve or whatever. You are literally trying to pharmacologically manage a person's sense of self.
Their whole history, really, their ability to recognize their own family.
Right. And it just forces us to confront the limits of how we view human biology.
It does. I mean, we really like the comfort of a simple cause and a simple effect.
Right.
But when the very essence of a person is what's fading, well, the expectation of what a chemical compound can actually achieve has to be completely recalibrated.
Which is exactly why we are doing a deep dive today into the surprisingly scandalous, deeply complex, and just absolutely fascinating world of Alzheimer's pharmacology.
It is a wild ride.
It really is. So based on the stack of research you provided, our mission for you listening today is to show you how a biological theory about human memory actually gets translated into a pill you can swallow.
Right, the actual physical mechanism.
Yeah. We're going to explore the incredibly strange origins of these medicines, how they physically work inside the brain, the fierce debates dividing scientists right now, and what all of this means for millions of families.
But to do that effectively, we really need to define our terms up front. Because the phrase Alzheimer's drugs is, well, undergoing a severe identity crisis right now.
Yeah, big time.
For about 30 years, that umbrella term meant one very specific thing, which was symptomatic treatments.
Meaning they don't actually cure the disease.
Exactly. They do not slow or stop the underlying disease at all. They just try to temporarily improve a person's cognition by, correcting chemical imbalances in the brain.
But looking at the recent medical news in your notes, that 30-year consensus basically violently split in two around 2021.
It did.
Yeah.
Because the FDA began approving a totally new category of drugs. These are monoclonal antibodies.
Right, you might hear them referred to by their generic names ending in mab.
Yeah, like aducanumab or lecanemab.
Yeah.
And these are heavily marketed as disease-modifying therapies.
Meaning they claim to actually alter the biological trajectory of the illness, right? Not just mask the symptoms.
Precisely. So today, the medical community is somewhat divided on the terminology itself, which makes navigating this space incredibly confusing for a patient.
I bet. Well, for our deep dive today, we are going to start with those symptomatic pillars. The older drugs.
Which are still the absolute backbone of everyday clinical practice globally.
And honestly, they provide the clearest illustration of how we try to outsmart a failing brain. But to understand them, we have to go back to the very beginning.
Right.
And the research notes highlight 1901.
Yes. That is the year a German psychiatrist named Alois Alzheimer began treating a 51-year-old patient named Augusta Tarr at a Frankfurt asylum.
And her case was just devastating.
Right. It was. She was suffering from progressive memory loss, severe disorientation, paranoia. And when she passed away in 1906, Alzheimer actually examined her brain tissue under a microscope.
And what he saw became the defining hallmark of the entire disease.
Right. He identified two distinct lesions. First, amyloid plaques, which are essentially these extracellular protein clumps building up between the brain cells.
Like gunk between the gears.
Exactly. And second, neurofibrillary tangles, which are twisted fibers of a protein called tau, and those are found inside the dying neurons.
Okay, so I was reading through the timeline in the source materials, and I actually had to double-check the dates on this.
Oh, yeah.
Yeah, because Alois Alzheimer spots these plaques and tangles in 1906, but the first real medical breakthrough for a drug doesn't happen until decades later in 1976.
Right. There was a massive gap.
And it didn't even come from studying those plaques at all. It came from a totally different intellectual thread.
It did. So British researchers Peter Davies and A.J.F. Maloney published a landmark finding that year. And they weren't looking at the structural clumps in the brain. They were looking at the brain's chemical messengers.
The neurotransmitters.
Right. They discovered that the brains of Alzheimer's patients had this dramatic deficit in a specific enzyme called choline acetyltransferase.
Okay, let's call this the builder enzyme.
I like that, yeah.
Yeah.
The builder enzyme. Its job is to manufacture acetylcholine, which is a neurotransmitter that is absolutely critical for learning and memory.
And this gave birth to the cholinergic hypothesis.
Exactly.
The idea that the memory symptoms are largely caused by the loss of these specific neurons. And, if we could just boost the levels of acetylcholine in the surviving brain cells, we could ease those symptoms.
That was a theory.
But here is the part of the research I found absolutely mind-blowing. The ancestor compound for this entire class of modern memory drugs. It wasn't invented in some sterile modern lab.
No, it is a staggering historical detour.
It really is. It comes from something called Rivastigmine, which is an extract from the West African calabar bean.
Right.
And historically, Efik tribal communities in Nigeria use this exact bean as an ordeal poison.
Which sounds intense.
It is. They would administer it to suspects during trials to determine their guilt. Basically, if you survived the poison, you were deemed innocent.
And chemists studying that ordeal poison realized that it worked by blocking a totally different enzyme in the brain, acetylcholinesterase.
Okay, so if the first enzyme was the builder, this one is the destroyer enzyme.
Perfect, yes. Its natural job is to break down acetylcholine so your brain doesn't just get overstimulated.
Because you don't want a signal just firing forever.
Exactly. And the researchers realized that this exact toxic mechanism, if they carefully controlled it, could actually treat the chemical deficit in Alzheimer's patients.
Okay, I like to visualize this biology like a bathtub. So imagine a healthy brain synapse is just a perfectly functioning bathtub.
Okay, I'm with you.
The faucet is pouring in water, and that's the acetylcholine being released by your neurons.
Right.
And the drain is letting water out at a steady pace. That's the destroyer enzyme breaking it down so the signal doesn't just flood the system and overflow the tub.
It's a very precise biological equilibrium.
Right. But in Alzheimer's disease, a specific deep brain command center for this neurotransmitter, I think it's called the nucleus basalis of Meinert, it starts to die off.
It does, yes.
So your faucet essentially has a slow leak. You are getting less and less water pouring into the tub,
Right.
and we can't easily turn the faucet back up.
No, we can't just drop more acetylcholine directly into the brain.
But we can mess with the drain.
Which is exactly what cholinesterase inhibitors do. Drugs like Donepezil or galantamine, they do not add more acetylcholine to the brain.
Right.
Instead, they partially plug the drain. They inhibit that destroyer enzyme.
So whatever small amount of acetylcholine the dying neurons can still manage to squirt out, it's left to linger in the synapse for a longer period of time.
Exactly. It buys the remaining neurotransmitter more time to connect with the next neuron.
It basically keeps the water level in the tub high enough to keep the system functioning.
It works for a while, yeah. But, I mean, it is fundamentally a dirty fix.
How so?
Well, you are artificially keeping the water level high, but the tub itself is still cracking. The underlying neurons are still dying.
Ah, right, because it's not stopping the disease.
Exactly. That's why the first drugs developed in the 90s, like Tacrine, were so flawed. Tacrine was incredibly hard on the liver and required constant blood testing.
Yeah, it was quickly abandoned for safer alternatives.
Right, like Donepezil, which is still widely used today.
And reading through the clinical profiles, there is also Rivastigmine, which really stands out to me because it's available as a transdermal patch.
Yeah, the patch is a really clever pharmaceutical workaround.
Because of the nausea.
Exactly. These drugs naturally cause severe nausea because acetylcholine is active in your gut, not just your brain.
Oh, I see.
So by delivering rivastigmine through the skin over 24 hours, you smooth out the blood levels of the drug. You completely avoid that sharp spike that makes patients so sick.
That's fascinating. Okay, so plugging the drain buys us some time with acetylcholine, but that's really only treating one part of the brain's chemistry.
Right, the brain isn't just plumbing.
Yeah, it's a massive, complex electrical storm. So what about the rest of the electrical system?
Well, that question leads us to the second major class of symptomatic drugs, and specifically a medication called Memantine.
And just like the calabar bean, Memantine has a completely bizarre origin story.
It really does. It was synthesized back in 1968 by Eli Lilly, but get this, they were investigating it as a potential treatment for diabetes.
I still can't get over that. They were looking for a diabetes drug, and it just failed completely.
Totally flopped. It sat forgotten on a shelf for over 20 years.
Wow.
It wasn't until a German pharmaceutical company named Merz dusted it off that researchers realized Memantine actually blocked something called the NMDA glutamate receptor in the brain.
Which linked up perfectly with a second, completely independent theory of Alzheimer's disease in your sources, which is the glutamate excitotoxicity hypothesis.
It's a mouthful, I know.
It is. But if you're wondering how excitotoxicity actually works, it really all comes down to background noise.
Exactly. So glutamate is the brain's main excitatory neurotransmitter. When it binds to that NMDA receptor, it opens a channel that lets calcium flow into the neuron.
And that creates the electrical signal for learning.
Right. But in Alzheimer's, the brain's environment becomes toxic. The background levels of glutamate, the baseline static, they rise chronically.
So it's like a constant low-level buzzing in the brain.
And that constant buzzing keeps the NMDA receptors partially open all the time. So a steady, abnormal trickle of calcium just floods into the neurons.
And over time, that excess calcium basically acts as a poison.
It does. It literally excites the cell to death.
Wait, let me push back on this for a second. You just said glutamate is the brain's main signal for learning and forming memories.
I did, yeah.
So if Memantine blocks glutamate, wouldn't that cause terrible amnesia and confusion? Like, you are blocking the very thing that makes memory possible in the first place.
And that right there is the genius of how Memantine was designed. It acts as a voltage-dependent, uncompetitive antagonist.
Okay, break that down for me. I like to think of Memantine as a bouncer at a nightclub, but a very specific kind of bouncer.
That's a great way to look at it. It sits right inside the channel of the receptor, but it only blocks the door when the channel is abnormally, persistently open.
When that toxic background noise is happening.
Exactly.
So it essentially kicks out the obnoxious, lingering static.
Right. But Memantine's grip on that door isn't ironclad. So when a normal, sharp, high-intensity burst of glutamate comes along...
Like the kind of burst required to actually form a new memory?
Yes. That strong signal literally knocks the bouncer out of the way.
Oh, wow.
The door opens, the memory is formed, and then Memantine steps right back in to block the toxic background noise.
So it functions like a pair of high-tech noise-canceling headphones. It filters out the static without shutting down the actual broadcast.
Which is why it dampens that slow poisoning process without causing the heavy sedation you would expect if you just crudely blocked a memory receptor.
Okay, so we have these beautiful biological theories, right? We have ordeal poisons turned into drain plugs and failed diabetes drugs acting as noise-canceling headphones.
It's incredible.
It is. But what happens when you actually hand these pills to a real patient? Let's look at the numbers here.
The clinical reality is often quite sobering. In 1998, there was this pivotal study that looked at patients taking Donepezil using a standard 70-point cognitive scale. It's called the ADAS-COG.
Right, and over 6 months, patients on the drug improved by roughly 2.5 to 3.1 points compared to the placebo group.
3 points out of 70.
That sounds pretty small.
I mean, for some families, that 3-point bump is incredibly meaningful.
Because it might mean a few more months of recognizing a grandchild or being able to dress themselves independently.
Exactly. It is real and it is measurable. But in absolute terms, it is modest. And crucially, underneath that temporary bump, the underlying disease is still destroying the brain.
Which is a vital distinction for you to understand if you're navigating this. These drugs are not cures. They shift the decline curve, but they do not flatten it.
No, they just buy time.
Huh.
Usually delaying the apparent decline by about 6 months to a year.
And that is the defining signature of a symptomatic drug.
It is.
But here's a question. If they shift the curve a little bit, why not just flood the brain? Why not triple the dose of Donepezil and by 5 years instead of 6 months?
Because the human body simply won't tolerate it.
Oh, because of the side effects?
Right. Acetylcholine doesn't just work in the brain. It operates throughout your entire autonomic nervous system.
It controls your digestion, your heart, your muscles.
Yes. So if you push the dose too high, you trigger extreme nausea, vomiting, severe diarrhea.
Yikes.
And even a dangerous slowing of the heart rate called bradycardia, which can lead to fainting and falls in elderly patients.
Which is obviously the last thing you want, which is why doctors have to slowly increase the dose over weeks rather than just hitting a patient with a massive dose on day one.
Exactly. You are constantly balancing the cognitive benefit against the physical toxicity.
But there is a silver lining here in the pharmacology, right? Because Donepezil and Memantine target entirely different systems.
Right, the drain plug versus the noise-canceling headphones.
Yeah, so because they operate differently, they can actually be used together.
They can. In 2014, the FDA approved a combination pill called Namzaric, which blends both drugs.
And trials showed that this combination produced modestly better outcomes on cognition than either drug alone.
It's a rare case in neurology where two treatments meaningfully complement each other without just massively multiplying the side effects.
But even as a tag team, they are still only offering modest temporary relief, which kind of explains the desperation in the field.
Oh, absolutely. Scientists knew they needed a drug that could actually alter the biological trajectory of the illness, not just treat the symptoms.
Yeah. And this hunt brought researchers all the way back to 1906.
Back to Alois Alzheimer, looking through his microscope at those amyloid plaques.
Right. Which brings us to the amyloid cascade hypothesis.
Yes. For decades, since the early 1990s, This has been the dominant theory in Alzheimer's research.
And the idea is pretty straightforward, right? The buildup of amyloid beta plaques is the primary trigger of the entire disease.
Exactly. If you can clear the plaques, you stop the downstream tau tangles and the neuron death.
I mean, it sounds perfectly logical.
The logic was totally sound, but the clinical reality in the 2010s was just brutal.
Billions of dollars were poured into amyloid-clearing drugs like bapineuzumab and solanezumab.
And they flopped in major phase 3 trials.
Completely. And the devastating part for researchers was that some of these drugs actually successfully cleared the plaques from the brain, but the patients didn't get any better.
The cognitive decline continued exactly as before.
I can only imagine the despair in the field. You hit your target perfectly, and the disease just ignores you.
It was a massive crisis of confidence. It led many scientists to question if the amyloid hypothesis was fundamentally flawed, or if we were maybe targeting the wrong type of amyloid entirely.
And this is where the story takes a really dark turn. I was reading the article you provided from the journal Science in 2022.
Right, the investigation.
Yeah, it detailed a massive scandal involving a hugely influential 2006 paper published by a researcher named Sylvain Lesnay.
And that 2006 paper, it was seen as a lifeline for the amyloid hypothesis at the time.
Right, because it focused on a specific subtype of amyloid called a beta star 56.
Yes, a beta star 56.
And researchers believed this specific protein cluster was the smoking gun of memory loss. It seemed to prove that amyloid caused the decline early on, before the massive plaques even formed.
But the science investigation found something pretty horrifying about how that paper was actually constructed.
They found apparent image manipulation.
Yes.
Specifically with Western blots, which are, essentially just tests scientists use to spot specific proteins in a tissue sample.
Right, it's standard lab work.
But the images showing the presence of this smoking gun protein had seemingly been doctored.
Which is just staggering when you think about the implications.
Which means that for over a decade, a massive chunk of the field's funding, energy, and thousands of intentional research hours were built on a potentially fraudulent foundation.
It is a sobering case study in how the momentum of a really compelling narrative can blind a scientific community to underlying flaws.
Because by faking the presence of that specific protein, it sent the field on a multi-billion-dollar wild goose chase.
It really did.
But despite that massive scandal, the amyloid theory didn't die. It pushed forward into a highly controversial new wave, the monoclonal antibodies.
Right, the newer drugs we mentioned at the start, the ones ending in mab.
Aducanumab, lecanemab, and donanemab. And they differ from the older pills in a few critical ways.
First, they are delivered by intravenous infusion, not an oral pill. And second, they target the amyloid itself, aiming to be disease-modifying.
But the controversy surrounding them has been, well, it's been unprecedented in modern neurology.
Absolutely unprecedented.
Let's look at aducanumab, which was approved in 2021. If the clinical data for clearing amyloid was historically so weak, how on earth did the FDA justify approving it?
That is the question that literally fractured the neurology community.
Because the FDA's own independent advisory committee reviewed the efficacy data for aducanumab and voted overwhelmingly against approving it, citing contradictory evidence.
Right. They basically said the data isn't there.
Mm.
But the FDA went ahead and approved it anyway under an accelerated pathway.
And the downstream effect of that decision was explosive. 3 members of that advisory committee publicly resigned in protest.
It was a huge scandal in regulatory circles. And ultimately, the drug was commercially withdrawn by its manufacturer in 2024.
Now, its successors, lecanemab and donanemab, they have actually shown statistically significant slowing of cognitive decline in their phase 3 trials.
They have. But the slowing is still modest. And importantly, it introduces a completely new severe safety concern that the older pills simply do not have.
ARIA.
Right, and amyloid-related imaging abnormalities.
Which is a very polite term for a very scary side effect.
It is, because by aggressively stripping the amyloid out of the blood vessels in the brain, these antibody drugs can cause brain swelling or microhemorrhages.
Tiny brain bleeds.
Yes, and it happens in a meaningful minority of patients. In rare cases, it has even been linked to fatalities.
Wow.
So the medical community is currently in a very live debate about whether the FDA's benefit-risk bar for these drugs is actually set correctly.
When you pull all of this together, it just completely shifts how you view an Alzheimer's diagnosis today. This disease affects tens of millions of people globally.
It's a massive public health issue.
And understanding the exact difference between a symptomatic drain plug pill and a disease-modifying 5e isn't just academic trivia.
No, not at all.
It directly shapes what families can realistically expect. It shapes national healthcare budgets, and it dictates daily clinical practice.
And if we look at the global reality, the contrast between these treatments is stark.
Yeah, let's talk about that.
The older symptomatic drugs, like Donepezil and Memantine, they are generic, inexpensive, and accessible in essentially every country with a functioning pharmacy.
Contrast that with the new antibody drugs. They cost tens of thousands of dollars a year.
And they require specialized fovea infusion infrastructure.
Right. And because of the severe risk of ARI, patients actually mandate regular MRI scans just to safely monitor for those brain bleeds.
Exactly. That limits these new therapies almost exclusively to the wealthiest health systems in the world, which creates a massive accessibility gap.
It really does. It leaves me with this final thought for you to mull over as we wrap up today.
Okay.
The story of Alzheimer's pharmacology proves that medical science is not a clean, straight line of constant progress. It is a messy, deeply human endeavor.
It's full of missteps.
Think about it. A poisonous African bean used in trials by ordeal, and a diabetes drug that completely failed its clinical trials.
Total accidents.
Those two accidents became the backbone of global treatment for human memory. Meanwhile, billions of dollars and decades of highly intentional, laser-focused research can be completely derailed by incomplete hypotheses or even manipulated images.
It really requires us to constantly question the narratives we build around medical progress.
When we started today, we talked about the simple transaction of taking a pill for a headache. The problem is isolated, the solution is targeted. But when we look at the murky, complex landscape of trying to save a human mind, you really have to wonder,
What's that?
how many other modern miracle cures are we currently viewing through equally flawed or incomplete lenses? Thanks for diving deep with us. Keep questioning the transaction.